This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here today with Dr. Lori Langdale, one of our CSAP 17 authors. And Lori, can you share with our audience where you are located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or usual week, if there is one of those?
Well, I have been in general surgery practice for over 30 years now, based in the Seattle area. I'm a professor of surgery for the University of Washington, but I spend most of my time, and have for virtually my entire career, worked for the Seattle VA, where I'm the chief of general surgery. I have probably one of the last academic broad-spectrum general surgery jobs in the world, for which I'm very grateful. That means that I get to practice general surgery in all the aspects for which I was trained. So while I spend about a quarter of my time directing the surgical intensive care unit, I do pretty much everything in general surgery, from endocrine through esophagectomies, Whipples, hernias, gallbladders, just about everything except for vascular and thoracic nowadays. My weeks are predominantly clinical, but with a heavy emphasis on education for the residents and students that are rotating through our facility. So it's really a pretty fun job, one that I've been very grateful for.
I am always impressed at your enthusiasm. So it must be a great position and a great job, and that's what we all look for in our careers. So I've asked you to share some of your thoughts today about various problems a general surgeon faces in the perioperative period. We will be discussing topics from CSAP 17 that are located in the perioperative category. Some of the topics actually come right from CSAP 17 questions, and others will be from questions that were written, but were not really selected for the final draft of CSAP 17. They're questions that I remember committees had a lot of discussion on, and I want to pick your brain about your thoughts on those discussions. So let's get started. One thing I always notice when we introduce a new CSAP issue is that there are topics that are commonly written about by many of the committees. And this year, perioperative anticoagulation was a hot topic. In the past, we've had many questions on warfarin, but today we have a new group of anticoagulation. They used to be called the novel oral anticoagulants, and now they're called the direct oral anticoagulants. How common are you seeing these crop up in your practice today?
Well, this category of anticoagulation is really huge. Its popularity has just burgeoned over the last several years, so we're seeing less and less warfarin. Presumably its popularity is because the drugs have a relatively short half-life and, from the patient's point of view, have a minimal need for any lab monitoring. But I think the challenge for the surgeons in practice has clearly been the potential for active reversal in the face of an emergency.
The CHEST guidelines have used, this is where one of the discussions came from, the CHEST guidelines have sort of pushed, especially I would say apixaban and rivaroxaban, which for our audience is Xarelto and Eliquis, as a easy way to bridge people who are on anticoagulation for various reasons when they're undergoing an elective operation. There's some thought even in a couple of committees that people should be, even if they're on warfarin, the warfarin should be stopped, transitioned to these drugs. They're more expensive, and then end up using these drugs for the bridging of a patient because they have, as you said, a short half-life. You stop them, you restart them, and then you can transition the patient back to warfarin if you choose. Are you seeing that kind of manipulation of these anticoagulation drugs?
Well, there's been this really huge shift toward not using warfarin at all. The use of preoperative bridging, we found, has been less and less frequent. that usually people can just stop the oral anticoagulant, the direct oral anticoagulant, and just wait for 24, 36 hours, operate fairly safely and with minimal consequence. There was, in fact, a large clinical trial that asked that very question: was it safe to forego bridging? And they actually found that there was really little difference in the stroke or thromboembolism incidence with or without bridging, and whether or not they were using the direct oral anticoagulants as the base therapy or Coumadin, warfarin. There was some bleeding risk, but not very much. And so we've really not seen a transition to bridging occurring very much at all lately. Now, there are some settings where Coumadin is still the preferred drug for anticoagulation. I think people just need to be aware of that. It's primarily those patients who have had a mechanical heart valve placed. In this setting, we have continued to occasionally advocate for traditional bridging with either with an oral anticoagulant or unfractionated heparin. It certainly occurs that heparin drip is still used in the post-op heart setting, that the mechanical valve has been placed, and then now within the next, or even a prosthetic valve has been placed, and then within the next, until they're ready to go on Coumadin and the cardiac surgeons are putting them on it, even if they have a prosthetic valve for several months, that they might be carried on unfractionated heparin as a drip until they can get into a fully anticoagulated range with Coumadin.
The other comments that were made in many of the committees was that it appears that the major use of these direct oral anticoagulants is with apixaban and rivaroxaban and not the dabigatran. Is that what you're seeing in your area?
Yeah, pretty much. I think that's true. The dabigatran, although its main pro is that it actually has a reversal agent, we have mostly seen those other drugs being advocated for, and I'm not exactly sure why, but unless it's cost. But that has been the trend.
Now, the reversal agents are available now for both drugs, the idaruzimab for the dabigatran and the alpha-dexanet for the apixaban and rivaroxaban. Do you have any experience with this? It seems like in our committee discussion, not many people have had much experience with the reversal agents.
And that would be our experience as well. Those reversal agents are not inexpensive. And that for the most part, our hospital is not a trauma setting. The emergent reversal has been less of an issue, and this is really, the drugs can just be held. They have a relatively short half-life, as we spoke about earlier. And so usually in the elective or even semi-elective setting, they can be held and not have to actively reverse the drugs.
So anything else that you've seen in the perioperative period regarding the direct oral anticoagulants that we should talk about for our audience?
Well, not specifically about them. I think that the one, I mentioned the issue around people with heart valves, and I think that that's something for folks to keep in mind, that it's not that warfarin has completely gone away, and keeping that in mind, especially in a preoperative evaluation of considering what to do with anticoagulation, is still not small.
Well, let's move on to a little different topic, and that's risk assessment in surgery. This appears to be a changing area, especially in the elderly. We've got a couple of different approaches in the CSAP questions using different risk assessment tools. So the first is the NSQIP, Surgical Risk Calculator. Is that something you routinely use in the VA?
Well, since we started NSQIP, I guess the answer to that is yes, although we call it VASQIP now since the NSQIP label was taken over by the American College. And we do use these calculators, particularly when discussing the risks and benefits of a high-stakes operation with a high-risk patient. Sometimes patients just sort of need to have a concrete value of estimating how much risk they have for when they're choosing or deciding whether or not to undergo a procedure. And that's sometimes much easier to understand than just that I'm worried about their outcome. As it happens, because the VA is actually transitioning to a different electronic medical record, we've already requested that this be an automatic calculation that can be inserted into the conclusions of our surgical consult, just so there's good documentation that people have considered the overall risks for a particular patient.
Let me just ask a question of how you use the calculator, because some surgeons I've spoken to like the numbers, some people like the graphs. What do you think your patients like best?
I think our patients like a number. It's incredible that I have a 50% chance that I'm going to do really poorly. And in what regard? That I'm going to die, or I'm going to have patients sort of don't seem to think that a wound infection is all that big a deal until they have one. But going into a nursing home or actually dying from a procedure makes a significant impression.
Do you have a feeling if one complication is more impressive to a individual patient than another, or does it vary from patient to patient?
Oh, I think it varies from patient to patient, but the low stakes ones that they have less appreciation for its potential impact is like a wound infection. Bleeding they see as, okay, you can give me a transfusion. But respiratory failure, or you're going to be on a ventilator for 2 months, that makes an impression.
How often does the calculator help you in deciding how much preoperative evaluation the patient should undergo?
I guess I'd have to say that it would influence it, but in general, I'm already aware of what the potential perioperative issues are from their overall comorbidities, and it doesn't necessarily push me to get more evaluation. Sometimes that additional evaluation is another mechanism to confirm the gravity of my concern and transmit that to the patient. So they're a patient who's pushing for a hernia repair that's unattractive but not clinically impactful, and understanding what the consequences of that choice of general anesthesia and overall risk is not readily apparent to the patient until they sort of understand that you're going to have to go through these multiple hoops, because we really are nervous.
Let me just clarify something for our audience again, and that you've got a 65-year-old carpenter who presents with a symptomatic right inguinal hernia. He's really got no significant past medical history except an open appendectomy. He denies cardiac or pulmonary symptoms. How much preoperative evaluation does that person get in your system?
Well, having already done the history and physical and review systems that you outlined, assuming that there's nothing else to worry about, we would get an EKG for those people. Anybody over about 45, male, 50, female, would get an EKG just as if they hadn't had one in their record. Depending on any medications, they might get some blood work done, but looking for electrolyte abnormalities or making sure their sugar was under good control. But without a significant history, that might not be pushed. They would all get a UA, mostly because we're putting in prosthetic material. But other than that, that person actually might not get a whole lot. If he was shown to be physically active, we could ask some questions with regard to exactly what do they do, what kind of work does he do. You said he was a carpenter, so that suggests he has some pretty significant potential physical activity. Whether he's had any previous operations might affect the choice of whether it's done open or laparoscopically. All those considerations go into it. But in terms of his pre-op, he might not get a whole lot.
Okay, all right. Just trying to make sure the audience understands that some people don't need much before they go to the operating room for an operation. So, well, the second risk assessment is frailty. And I guess NSQIP is going to put into their risk calculator some frailty metrics. Do you add any assessment to your patients for frailty?
I would say that we do not add a specific calculation about frailty.
Okay.
However, I do ask a lot of questions that are very similar to those that are included in those calculations, that go beyond what one might get from an evaluation of medical comorbidities and a review of systems. And that often sort of starts with, what do you like to do? And which gets us toward, are people able to climb stairs? How much activity do they do? The degree of independence, what kind of support they have. And it's not uncommon that this just is a little bit of an eyeball test, but there are ways, as you say, to put some kind of concrete evaluation to this. And this too probably will end up being slotted into our new medical record assessment.
So you don't use anything like the timed up and go test or strength or grip strength to assess frailty in your patient population?
We haven't added that specifically, but I have to admit, I guess in some ways, although it's certainly not scientific, there is kind of an eyeball test as to what can people do, and I get a sense of how much actual activity or things they're doing in their daily life that would be impacted by whatever operation I'm potentially offering.
So one of the discussions that one of the committees had is, how do you explain frailty? And the question was, is frailty really disability? How do you view it in your practice?
In some ways, I can see where someone would call it disability, but where many people look at frailty are things like, if you're elderly, how fast can you walk down the hall? And if you're kind of speeding down the hall, you look frail. You're thin, you're older, but you're not actively frail in the sense that you can still do quite a lot in your day. And that's why I asked the question, what do you like to do?
And in some of the literature that's coming out about frailty now, they seem to talk about it as a chronic, low-level inflammatory process. How do you feel about that?
I guess I don't have enough data to support that one way or another, but it wouldn't surprise me if there were elements of that kind of physiologic impact, particularly if one applies that to people who were otherwise might not be considered to be frail.
Well, let's go back to some drugs again and how they impact your or our elective practice. So you kind of mentioned this a little bit with the direct oral anticoagulants, but let's talk about antiplatelet drugs. So a patient who has had a stroke, got atrial fib, and needs an elective operation. And how do you manage that? And let's say they're on dual antiplatelet agents for their stroke therapy, and do they continue those through the operation, or does it depend upon the operation you do?
Well, certainly in the setting of an elective procedure, let's say a herniorrhaphy, we would recommend that the patient just delay that elective operation for at least 3 to 6 months after the stroke, ideally with resolution of their neurologic symptoms, but at least a non-progression of their neurologic symptoms. And then at the time that they got their operation, then we would keep them on the aspirin, but hold the clopidogrel or Plavix for at least 5 days prior to the operation. Some of the vascular surgeons will continue someone on both aspirin and Plavix, especially if they think that the source of the stroke was the carotid and they're doing a carotid endarterectomy. And thank goodness that's a relatively superficial operation. So while there's consequence to a local bleed that is not insignificant, at least it's visible and you're not worrying about something that's, say, intra-abdominal and less excessive.
And when you stop these antiplatelet drugs, do you stop them just immediately pre-op, or do you have to stop them a longer time than 24 hours before the operation?
Plavix takes a long time to go away. So ordinarily at least 5 days and maybe upwards of 7 if it was an operation that had significant bleeding incidents. But we would keep the aspirin on. We've never really noticed any negative to that, and it provides at least some minimal degree of protection in that setting.
And when do you restart the Plavix?
Well, that depends on whether they're eating, because that's oral. Usually within, if they are taking PO, we can restart it within about 48 to 72 hours, as long as we're convinced that there's no additional or impending bleeding risk.
Okay, let's move on to another topic, that is surgical site infection. You live in an institution that's got lots of experts on this, so let's talk about a few things. So pre-op, showering or directed wiping seems to be the competition out there, with directed wiping with impregnated cloths at the surgical site, impregnated with chlorhexidine. So what's the belief at the University of Washington?
Well, we've run the gamut on this. For a time, patients were asked to use those chlorhexidine wipes over taking a soap shower, and our infection rate went up. It basically came down again when we reinstituted showering, cleanliness next to godliness. Patients just seem to find it easier to be compliant with a shower. So we have gotten rid of the wipes.
How about when somebody is in the hospital and needs an operation that may not be planned but needs an operation? Do the nurses go around and wipe the site with these cloths, or you can't find the cloths in your VA anymore?
Well, we can still find the cloths, but in general, that for someone who's hospitalized, say coming off from the medical service, they probably don't actually get anything except for the general bathing in the hospital. We are, however, starting to do it to ensure that people have manual bathing by the nurses in the ICUs every day, mostly just to make sure that we don't have an increase in wound infection rates in the high microbial environment of an intensive care unit.
What about a hair removal from the surgical site? Has this just stopped completely?
Well, I'm a big proponent of minimal hair removal, if for no other reason than when it grows back, it itches like heck. And then patients violate their skin by having scratched. We still have the occasional patient who wants to be helpful and shaves themselves the night before, in spite of instructions not to do this. And we're sticklers about this, and we'll even cancel or reschedule a case, especially if mesh is involved. Those little nicks really up the ante with regard to potential wound infections. In the operating room, we clip.
Okay, do you clip everybody, or when the hair is not a major issue, you just leave it alone?
I would say almost everybody gets clipped a little bit, but not extensively.
Well, let's go to the topic that all surgeons like to talk about because there's a lot of emotion involved with it, and that's pre-op antibiotics. Well, first of all, do you have favorite ones for favorite operations? Is there such a thing as standardization within your VA of what drugs can be ordered?
There is, actually. There's all kinds of rules and regs about this, and some of it is related to our own biogram. Obviously, antibiotics are just like anywhere else. They are tailored to the patient's allergies and MRSA status. We generally adhere to a recommended infusion of prophylactic antibiotics that is, for most operations, is a cephalosporin or vancomycin if someone has a significant pen allergy or is known to have MRSA. And that's infused within an hour of the incision and only repeated if the case runs long or there's greater than about 1,500 cc's of blood loss.
Now, you mentioned MRSA, so let me give you two scenarios to see if you can help sort out what we should be doing. So, the one is that the patient is known to have had an infection with MRSA in the recent past, let's say within the last 30 days. What do you use in that patient?
That person in general is going to get treated, I think, covered with vancomycin. We haven't done double coverage for those unless it was a pretty invasive infection, but that's, I think, what we would do.
Okay. Now, let's talk about colonization with MRSA. First of all, do you screen any of your patient populations for colonization with MRSA in the nares or the groin creases or anywhere?
We do. We screen virtually everybody with a nasal swab. Whether there are good data behind that, I'm not absolutely sure, but we do.
Okay, so now you've got your nasal swab that's positive for MRSA. Please tell us what you do with that information.
If someone were positive for general surgery, their preoperative antibiotics would be altered to include vancomycin. If they are a vascular patient, they even go so far as to do decolonization or attempt it.
My next question, though, which is one that I discuss with our vascular group all the time, so they like to not only give them an MRSA drug, but they also give them their standard prophylaxis as well. So if they're putting a graft in, it's usually cefazolin, and if they're colonized with MRSA, they give them vancomycin. So it's double drug perioperative coverage. Is that what happens in your institution?
Yes.
Okay. I'm not sure I agree with that, but okay.
That's what they do.
I understand. So the other question that is always there is, how do you give the drugs? Where do you give them? How often? How long before the operation? Is this always done by the nursing staff, or is it done in the pre-op holding area? Tell us a little bit about how you've tried to standardize that.
We would love if it was started in pre-op holding, but in general, we've handed this to the anesthesiologist, and they start it as pretty much as soon as the patient has undergone their initial timeout, verifying who and what we're doing for the day, and that the patient's known allergies, what drugs are there, and then they start infusing. So it's in the operating room is when that really gets started for us.
Let's talk about colon surgery. There's not been a lot of changes in colon surgery pre-op. That's a joke, but are you a bowel prepper or not?
I have always been a bowel prepper. The phase that we went through of not prepping at all or doing mechanical preps without oral antibiotics, that resulted in a significant increase in our wound infection rate. And so I was delighted when the data came out that said if you did a mechanical prep with oral antibiotics and IV antibiotics the day of operation, that your infection rate declined.
Now you have a statewide collaborative that has presented some information about colon surgery that wasn't as clear cut, if I remember right, that bowel prep plus oral and IV antibiotics are always needed. Is that right, or do I remember it wrong?
Well, people's behaviors are still, I think, evolving.
Oh, okay.
The process of not prepping was sort of au courant for a while, but I think people are shifting back now that wound infection rates in particular may be almost a never event. The folks who do laparoscopic colectomies, I don't understand not prepping in that setting. It's a lot easier to grasp the colon when you don't have a lot of stool in there. But some people feel strongly, and there are some data to suggest that laparoscopic surgeries do fine or at least equivalently without a bowel prep. So that may be influencing people's behavior.
And when we talk about bowel prep now, the the two that are always out there competing is the Nichols-Condon, where you take a long time to prep, and then the other one is the kind of go lightly prep. In your institution, what's the most common one that's used?
Most of the time, it's the go lightly or mag citrate. Our pharmacy doesn't carry the gentler new lightly on formulary, so we're sort of stuck with that. Adding oral neomycin and flagyl, and then adding IV prophylaxis at the time of the actual operation.
So it's kind of a manipulation of the old Nichols-Condon prep, what you're commonly using.
I think it's compression of time that for what patients are willing to do and able to do. The Nichols prep originally took about 3+ days to actually do, and I don't think we've actually utilized that degree of preparation for a very long time.
Now, you also have a proponent at your institution about normothermia in the operating room, especially for colon surgery. Is that routinely monitored and accomplished?
Yes, we are pretty focused on a patient being normothermic. Almost everybody has a warming blankets on for almost any case that's anticipated to go longer than about 3 hours to achieve that goal. Room temperature is for the patient's comfort, although with the warming blankets, it's easier to maintain them and keep the surgeons comfortable too. Fortunately, we're not in the burn setting, so we don't have to crank it up into tropical areas.
And the other thing I also know about your institution is that excess oxygen seems to be another way to improve or to lower surgical site infections, especially with colon surgery. Is that routinely done?
That's been a hard sell. Having appropriate oxygenation, especially in our significant COPD environs, is harder to sell to people, to have them on excessive amounts of oxygen. But everybody goes to the recovery room on a face mask pretty much, even if they're not overtly hypoxic. It doesn't last long because patients pull it off. But we haven't done that as a major focus as much as the normothermia and managing the people's glucose. Intraoperative glucose management has been a significant push.
And has anesthesia bought into that with you?
At some institutions, more than others.
Okay. All right. Let's move on to some specific drugs. The first one that it seems continues to crop up is the patient who's on prednisone. And let's start with a patient who is receiving 5 milligrams of prednisone in your institution. It may be for the COPD, and you need to take their colon out for cancer. How do you manage the prednisone in that patient?
Somebody who's on like 5 milligrams, I wouldn't be at all worried about. And as you sort of alluded to in setting up the scenario, we just sort of want to know why the person's on the prednisone, how much, and for how long. So if they had an active COPD exacerbation and they'd had a bump in their steroid use, obviously we'd want to see some resolution before proceeding with an elective procedure. But 5 milligrams a day should not invoke any kind of adrenal insufficiency, and we would not have a problem with just proceeding for that patient.
10.
Even 10 is I would say up to, if it's a chronic prednisone dose, up to maybe 15 a day or less. I sort of don't worry about stress dosage requirements. When it gets up to 20 to 30 a day for many years, we might, or the anesthesiologist might want to use hydrocortisone and rapidly wean, but it shouldn't be an issue for most people.
You kind of answered my question, but let me be more direct. So when you have that patient on 10, you think they've been on chronic, it's long-term, they're used to it, and you're going to take them to the operating room and you say, well, we don't need to do anything. How often does your anesthesiologist push back and all of a sudden you notice that they've got stress dose steroids being given?
Not very often unless the chronic dose is pretty high.
Okay.
And we have that discussion ahead actually during our timeout as to whether or not we're going to use it.
Okay, and when you have to use it, or when you do use it, do you have a standard dose that's used in your institution?
I would say that the anesthesiologist generally will push about 100 milligrams of the hydrocortisone, and then we'll do a rapid wean taper, if at all possible, over the next 2 to 3 days.
Okay, so it takes you about 2 to 3 days to get them back to their standard dose.
Right.
Okay. All right, what about beta blockers? Patients taking beta blockers for hypertension, and they're coming to you for an elective operation. Do you continue those or stop them for a certain time preoperatively?
I think, John, there's relatively little controversy here. That patient who's already on a beta blocker remains on it, using IV replacement if needed if they can't take their oral meds. Keep statins on, too, for a similar reason. There are good data to say that stopping it in that setting increases the chances of a cardiovascular event and even death. So those people do not stop their beta blockers. If we run into normal or lower blood pressure than their usual in the perioperative period, we can always decrease the dose, but we certainly don't stop it.
Well, let's talk about nicotine as a drug. Do you ask your patients to stop smoking before elective surgery?
You bet.
And how long do they have to stop?
Well, quitting smoking is tough. And certainly encouraging smoking cessation is a major focus for our primary care folks, and there's actually a smoking cessation clinic. We'd really prefer that a patient quit at least a month ahead of time. There are pretty good data that says if they decide to quit within 2 weeks of the operation, that they'll actually have some rebound sputum production and increase their pulmonary complications. So if we can, and the patient's honest and tells us that they have not stopped smoking, we might delay an elective operation if at all possible. There are some operations, however, for which smoking is a deal breaker. One of those is one that I do not infrequently, and that's an esophagectomy. And I tell patients this before they even start on any neoadjuvant treatment, that they don't stop smoking, that surgery is off the table. And then there's substantial evidence that suggests that smoking impacts recurrence and infections in mesh ventral hernia repairs. So we're getting more and more strict. We do test people for nicotine if they're undergoing one of those specific operations.
I don't know if you have any information, but in your practice, and then I guess in your clinic, do you have a success rate that you can relate to patients who enter a smoking cessation program?
As I said, quitting smoking is really hard, and people need a lot of encouragement to really be successful. I would say for some of these high-risk procedures, if patients really understand that it's a no-go if they don't stop smoking, they actually do pretty well at trying to really work at it and make it happen. I can't tell you what the cessation clinic has as a success rate, but my own patients, they understand that they're not going to get their cancer taken out with an operation, that they're going to rely on the chemotherapy and radiation. I've gotten most of them to quit.
Let's take another hot topic. Obviously, opioid use is something that is on everybody's mind these days. So let's talk about perioperative pain management and whether epidurals or other analgesic methods are commonly used in your institution or in your patients.
We do use epidurals, in particular as part of our ERAS or Enhanced Recovery After Surgery protocol.
And drugs that you use?
It's a multifactorial approach. The epidurals themselves involve an infusion of diluted bupivacaine and hydromorphone that can be adjusted by altering the rate or the concentration of those drugs. So if we see a patient who seems to be hypotensive, unresponsive to other solutions, and rather than turn the epidural off, we would potentially what we call splitting the epidural, take the hydromorphone out and give intermittent IV opioids as necessary, and potentially further dilute the bupivacaine so there's a rate but at a lower concentration to be effective.
Do your perioperative epidurals go in pre-op or post-op?
Pre-op, if at all possible. Now, there is the occasion where it went in pre-op and it wasn't all that functional and they might have to replace it post-op, but in general, it's a pre-op insertion.
Okay, and so the competition between putting an epidural in and giving pre-op VTE prophylaxis or venothromboembolism prophylaxis, who wins that competition?
The anesthesiologist they put the epidural in, and then we will still give sub-Q heparin in the operating room immediately prior to the operation.
Okay.
They don't seem to have a problem with that.
Is that right? Okay.
Yeah.
That was a big discussion in many of the committees about how to manage the placement of the epidural and how to get adequate prophylaxis preoperatively with the anticoagulation. So in your institution, the competition does not seem to create problems. Not
that I've noticed, no.
And this hypotension you just talked about, that was another common comment that epidurals weren't being used because hypotension was so common, and this was a major problem that the surgeon just did not want to face. Not a problem in your institution.
Well, it's a problem, but we've actively chosen to be, we're pretty sensitive to it. The pain team are responsible for managing that epidural, and we call them at all hours to manage that. The key seems to be a willingness to alter the concentration, particularly of the bupivacaine. And then if we take the hydromorphone out and give things intermittently, intravenously, we've avoided massive fluid resuscitation from the vasodilation and just flooding people. So that's what we're really trying to balance, is the limitations of fluids versus adequate pain management. We've also, in our protocol, used some other agents to try and augment the perioperative pain issue with oral preoperative gabapentin, Tylenol, Celebrex in various combinations depending on the patient's status with liver or renal disease, using additional tap blocks if the epidural fails. We try to make this a multidisciplinary approach.
And the tap block, is that done mostly by the surgeon in the operating room, or is it done by your anesthesia pain team?
It can be done by the surgeon, but in general it's done by anesthesia, the regional pain team.
And your use of epidurals, are they congregated in one part of the hospital? Are they all in the ICU? Are they all on a postoperative ward? How do you manage that?
They used to all have to go to the ICU, but our nursing staff has really been terrific about expanding their practice, so most of the epidurals go to the floor.
And Foley management is always the other bugaboo with an epidural. Any tricks, any help with what you do when the Foley is supposed to come out at 24 hours? Do you still have an epidural? Is that an indication to keep the Foley in?
Not anymore. We used to keep a patient with a bladder catheter until an epidural came out. I suppose there's two caveats. One is very, very low pelvic surgery. Those patients will tend to leave the Foley in longer, mostly just by virtue of the kind of operation they had. And then our population being predominantly male and older, if they have signs and symptoms of bladder outlet, they are normally on Flomax or some variation on that theme. We'd like to get them back started on that medication before we take the Foley out. But the goal is to get it out as quickly as possible. And for most cases, if the epidural coverage is T10 or above, or maybe even lower than that, above the sacral nerves, then most of the time we can get away with it coming out.
And then the last thing is, so you've got a patient who is 2 to 3 days out. The pain management has been superb. They're on their VTE prophylaxis, and somebody says, well, it's time for the epidural to come out. How do you manage the anticoagulation, or how do you and the anesthesia team manage the anticoagulation?
For the most part, if they were on sub-Q heparin as their management choice for the VTE, then just making sure that they have not had their next dose, which is usually not necessarily a BID drug in that setting. They're okay taking the epidural out. We basically just hold a dose, and then they'll take it out, and we wait several hours, and then we'll reinstitute the VTE prophylaxis.
And how about low molecular weight heparin?
That seems to vary with the anesthesiologist. There are some who are comfortable just holding the next dose and then taking it out. There are some who are much more rigid about it. Most of the time, we've not really restarted, especially in like our cancer patients who are going to have a new addition of a oral anticoagulant for 30 plus days after discharge, that we just don't start it until the epidural's out.
You mentioned opioid use added to an epidural when hypotension is a problem. Have you adjusted your use of opioids perioperatively in this world that we now live in?
We really do believe in the kind of ERAS protocol philosophy of epidurals, limited fluid management, early ambulation, get people going. And with that multimodal protocol that I mentioned, have significantly decreased the amount of opioids that people utilize in the hospital and are requiring in their post-discharge recovery.
And intraoperatively, have your anesthesiologist bought into the idea that excessive opioid use intraoperatively is a risk factor for abuse or misuse, let's call it, postoperatively?
Well, we actually haven't talked about that. That's an interesting question. I should probably pose that question to them. They're very acutely aware, particularly in the perioperative period. If people are having escalating apparent opioid requirements, then we've shifted to things like ketamine infusions, which, despite its long-standing reputation for its dissociative effects as an evil drug, it actually is extremely well tolerated and can also be managed on our regular surgical ward. So that's been another addition. I think the patients who have the most difficulty are the people who are already on chronic pain meds, including methadone. It takes a lot of thinking out of the box to develop a good pain management plan for some of these folks who are already on a chronic pain program to manage the now acute on chronic pain situation.
Boy, you just brought up two great topics. Let me ask you about both of them. So the methadone patient, do you use your anesthesia team to help you manage those patients, or do you use a addiction service or a palliative care service? How is that done at your institution?
Well, initially it mostly falls to the anesthesiologist, but we actively include the addiction teams because most of these patients, or many of them, already have a pain management contract, and we want to make sure that we are not putting that in jeopardy.
And your comment about ketamine. Now, are you using IV ketamine? Are you using oral ketamine? How are you finding that to fit into a multimodal pain management schema?
For the most part, it's an infusion, and they manage it by taking away some of the opioids and substituting the ketamine in it. Amazingly, for some people, particularly folks who are in the chronic pain population, this seems to work incredibly well. I
would have to agree with you completely. And despite the fact that we didn't see a question about ketamine. I am impressed that it's probably going to creep into our practice more and more. And your comment about the dissociative symptoms not being a problem is also our experience. So it's something to pay attention to, I think. Okay, so let's move on and let's talk about, it's really perioperative, but let's talk about damage control laparotomy, which has clearly moved from trauma patients to patients with severe peritonitis, i.e. general surgical patients. Do you have any routine ways to decide when you do this in a patient with severe peritonitis?
Well, as you say, in the non-trauma setting, the situation is almost always either massive peritonitis or mesenteric ischemia, and really reflects the gravity of the situation. For us, the patient who's approaching being hypothermic despite all means of support, who's hemodynamically unstable on pressors, whose organs are starting to fail, they're coagulopathic, have worsening renal function, they're hypoxic. This is clearly a person who doing what's minimally needed and getting out of Dodge is really important. In that setting, we would settle for addressing the primary contamination control, resecting anything that's clearly dead, and focusing on what can be safe and not worrying about being perfect. We would not perform any anastomoses, maybe not even a stoma, because we would intend to return that patient to the operating room within 24 hours for a second look after resuscitation and stabilization in the ICU.
And your temporary closure, do you have a favorite, or is that surgeon dependent?
I'm sure it's surgeon dependent, but I have the privilege of having a partner who actually rotated through Afghanistan. So we have the incredibly cheap but available approach. So our temporary closure is a variant on a backpack closure. And it starts with that we just literally open a bowel bag, get rid of the strings, obviously, cut it open so it's lying flat, and perforate it with some little vent holes. And then the bag is laid over the bowels within the abdominal cavity, overlapping the fascial edges by a good 5 to 10 centimeters. And we cover that with a layer of Curlex, followed by some couple of JP drains, and then an additional layer of Curlex. And then that whole thing is secured with Ioban. The drains come out the bottom of the wound, and then they're covered with the Ioban for a length of the tubing away from the wound edge. And this is actually a nice pearl that my partner taught us, that if you do this, it seals the edges of the wound and you have less trouble with leak when you attach the drains to wall suction. And this closure can be repeated if there are serial takebacks are needed. It works extremely well.
Obviously, when you have those multiple takebacks, the trick is to stop loss of domain. Do you use any specific suction amount or anything besides that bag to stop the loss of domain? Do you have any other tricks you want to share with us?
Well, for the most part, unless that abdomen's going to remain open for longer than a few days, we've been able to get away with just that closure that I just described. If we think it's going to let go longer, and this really is reflective of almost a trauma situation, but occasionally a really large closure or widely open abdomen. I don't like do necrosectomies for pancreatitis through the anteriorly anymore, so that fortunately is not common. But you can sew a piece of Vicryl to the edges of the wound and then gradually sewing the two pieces together in the middle, and then you can actually shore that together. It's almost like treating an omphalocele, but you can do that and improve it, minimizing any loss of domain. But we've not had it, unlike the trauma setting where that would be much more common, we haven't had to do that very often.
Obviously, one of the problems in these patients is they usually get bowel edema, they've got excess fluid on board, and certainly diuretics is one of the key issues to try to get them closed. There's also some talk in the literature about 3% hypertonic saline with an open abdomen. Have you had any experience with that, or have any of your surgeons tried that?
I do not have experience with that. We fortunately have been able to get people back together usually within 48 to 72 hours, but it has been advocated.
When you close the fascia in these patients, let's say you're successful in bringing them back in 48 hours, do you make any attempt to do any kind of different closure in these patients than you normally would do, closing a midline laparotomy?
I generally don't. There are all kinds of proponents of the continuous versus interrupted use of whether or not you're going to use retention sutures, and that's going to be an argument until there are no surgeons left. I don't think this is a setting to try to do these, 5 millimeters from the edge closures. Some people might advocate for that, but these people are generally have ongoing illness, and I tend to just kind of close them without trying to get very fancy about it.
Let's take another question from CSAP 17, which was extremely interesting, especially the discussion then that went back and forth. And actually, it's just been a discussion that was on the communities as well. And the question revolves around surgical garb in the operating room. Let me just ask you, type of headwear that is used in your institution. Do you have a difficulty deciding which type to use?
Well, no. I mean, the data for this is so weak and it's all over the map. Some of our surgeons just love to wear their Seahawks cap, and for the most part, the women are in there with their little bouffant caps that are provided by the operating room. We just have not bothered to get too excited about that. One of the things that is a big push is covering beards and things. That's been a requirement, but for the most part, we just haven't gotten too crazy about it.
You haven't, okay. What about surgical scrubs? The question really asks the question, is there evidence that says surgical scrubs are necessary?
Well, I'm not willing to operate naked. So I'm just saying, but there are no data, there's just never going to be a clinical trial about it. And so I think it's a matter of people just being logical, that something clean is ideal. I don't particularly like it when people are walking in and out of the hospital. You see people, at the mall and in their surgical scrubs. I somehow find that disconcerting. The data about anything specific other than something being clean is pretty sparse.
And you mentioned walking in the mall with your scrubs. Are there any rules and regulations about wearing surgical scrubs outside the operating room at your institution?
There are. That doesn't mean people don't violate it all the time. Particularly the residents will go from a hospital to hospital. We really have to remind them that these are not to be worn outside of the operating room setting.
Our VA solved that problem with the residents by changing the color of the scrubs to one that only the VA had. So that kind of identified everybody very quickly. So
yeah, all of our institutions have done that. The residents can look and say, "Those are Harborview scrubs," and and then we have to admonish people for wearing them at all.
In the same question, there's a question about whether covering the wound with a dressing has enough evidence to make it mandatory for all wounds. What do you feel about that?
Well, we certainly don't do it for all wounds, because if we use additional skin glue after a subcuticular closure, we don't put a dressing on top of that.
Huh. And if you put a dressing on, does it stay on in perpetuity until the wound's healed, or do you remove it in the ward?
That's kind of surgeon dependent in a way, but usually within 36 hours that dressing is changed or removed, unless there's a lot of strike through and you're just really using it to catch drainage.
Well, I've got a couple of post-op questions, which is perioperative. And the first is that we've got a lot of not a lot, but a few questions on the nuances of the Stop It trial, which was the trial that suggested 4 days of antibiotics are adequate for an intra-abdominal infection, or at least equal to a longer duration. So do you agree with that, and is that pretty accepted in your institution?
It is accepted. I think the beauty of this trial was that in essence it gave people permission to stop antibiotics. And as a result, we are potentially going to be better stewards of it for our contribution to infection control. Yeah, I admit it sometimes takes courage, and it may be emotionally difficult to actually stop antibiotics when it's not clear that the source of infection has been definitively managed, or that there's worry that there will be breakdown of an anastomosis, et cetera. But the trial was pretty definitive and really does support stopping antibiotics much earlier than we did before. Now, there clearly are exceptions to that. There's patients with an open abdomen or multiple organ failure may warrant a longer course. And one thing I think is important is for us and our infection control colleagues to not conflate these data with other situations that may warrant longer antibiotics, like mediastinitis as an example.
There was one interesting discussion at one of our committee meetings about the Stop It trial, which says 4 days of antibiotics after source control. And the question was what the study actually means postoperatively. If you give pre-op antibiotics and source control is achieved, would you stop the antibiotics at 3 days or 4 days postoperatively using the first day as the pre-op day? What do you think about that discussion?
I think we would count the operative day as day one.
So if you had a patient who comes in, you think they have a perforated viscus, they have peritoneal signs, you give them antibiotics, take them to the operating room, that's day one. And so postoperatively, it would potentially be only 3 days post-op, correct?
That would be true.
Huh. We did not come to a conclusion, so now I have a conclusion that I can quote somebody about.
Well, I don't know that I'm right. It's just that that's how we would interpret day one.
Okay, all right. Well, let's move to a topic that I believe you've mentioned at least twice already, and that is ERIS protocols. And I want to specifically address the part of ERIS protocols that is directed, I believe, at preventing ileus or promoting return of GI function. And in your protocols, do you use anything specific to promote return of GI function? And the obvious two that everybody talks about is chewing gum and using a pharmacologic agent. Alvimipam is the one that everybody talks about. So are those, one of those or both included in your ERIS protocols?
Alvimipam is part of our protocol, but clearly, as is well known, this has to be administered pre-op. And so if it gets missed somewhere, then it's no longer available from our pharmacy. It's either pre-op as part of that protocol or it's not available. The addition of gum chewing, well, I have one partner who's a big believer. It certainly doesn't harm anybody, and we have used it on occasion, but it's not kind of a general routine.
So you've got surgeons who firmly believe that alvimipam is part of a unique approach to prevent ileus and that it does offer benefit to the patient in preventing ileus.
We do, and as it has been a piece of that ERIS protocol, and it just, if someone, however, misses that dose or it was not given, then we just have to treat people as if they've fallen off the complete protocol. But that doesn't mean we don't approach other aspects of early recovery in a similar way, even if the drug has been missed.
And in your protocols, most commonly, when do you feed a patient after a laparotomy?
So open versus laparoscopic. Obviously, laparoscopic generally can go even earlier. But for an open procedure, we'll offer the patient clears on the first day, so post-op day 1. And if they're doing well, advance them to regular food fairly quickly. We don't go through what we used to do many, many years ago when you and I were growing up, of, full liquids and soft diets and all that stuff. We just give them food, and if they're able to take it, they do. But we watch them carefully. If they're not improving or they are uncomfortable, we'll back off.
And foregut surgery, NG tubes or not?
We hardly ever use an NG tube anymore. These are all the changes that have happened, over the course of time. There are a few operations that we still have an NG tube in perioperatively, but not very many anymore.
And do you find that you have more difficulty staying on the ARIS protocol with the elderly patient, or is it really just very individual patient response?
I think it's pretty individual. And sometimes where people seem to fall off is where their procedure was more complex than was initially thought it was going to be. But a good chunk of it, I think, is managing people's expectations about what's going to happen to them in the perioperative period. If somebody believes they're going to take 5 days before they're going to eat, that's how long it takes them before they're going to eat.
We also have a question about post-discharge instructions. And certainly at my institution, I've seen these gain in popularity, and everybody wants to write them down and hand them to a patient. There is one in CSAP about ileostomies, and I'll just go right to the heart of the matter. Do you think these really help in the post-op period when given to the patient?
Well, again, this is a question of managing expectations, giving people a heads up of when do you need to call and not tough things through. I actually think the biggest bang for the buck here is in pre-op instructions. When it comes to someone with an ileostomy or a colostomy, assuming that this was anticipated, that they were going to need this stoma, we have a tremendous stoma therapist, and I send them to her ahead of time where they learn about their appliance in advance. She talks to them about what to expect in terms of output. I will offer them the opportunity to meet with other patients who are living with stomas. It really helps when people are clear about what is going to happen in their life. Now, if the stoma is unanticipated, then that therapist addresses all these issues while they're in the hospital. Some of it is about giving people reminders. This is what you can expect and what you can do about it and when do you need to call. I think the data surrounding those discharge instructions really had a lot more to do with more frequent checking in on how are you doing than it had to do with something being written down.
Let me ask you about one of the operations you said you still commonly do, and that is esophagectomies. And so let me ask you about a leak after an esophagectomy. Has that management changed in the last few years with the appearance of some better stenting of the esophagus in any way, shape, or form?
Well, the vast majority of esophagectomies in our institution are done as a transhiatal approach, which means, as you know, that the anastomosis is in the neck. At most of the time, that anastomosis eventually kind of sits at the thoracic inlet. And leaks, at least stent management, can be difficult in that situation. Most of the stents are a little too long. Their cricopharyngeus is tickled all the time, and patients just don't tolerate it. So if I have a leak in the neck, I'll manage that with just opening the wound. But I have tended to do things also a little prophylactically. When I do that anastomosis in the neck, I usually mobilize one of the strap muscles fairly high off the trachea and roll it down and use it as a muscle flap. One of my partners who does these does not like to drain. I usually do put in a Penrose drain. Just gives me, I don't know that it makes a huge difference, but it gives me solace to be able to see what's coming out. The stents may be helpful if it's a mid-thoracic anastomosis, but we've not had good compliance or tolerance of a high cervical stent.
Have the newer drugs for esophageal cancer changed or helped manage many of these patients?
Certainly, I don't think it has any effect on a leak.
Right.
But the protocols for esophageal cancer are really so much better in recent years that we've had maybe 25 to 30% of patients who, on pathologic examination of their specimen, have had a complete or near complete response. So the day we can predict it by some means to say you've had a complete response and don't need to proceed to esophagectomy, well, I'll get on the plane and pick up my prize in Sweden and that'll be okay.
Okay. Lori, I see our time is about up, and I really have enjoyed talking with you this morning about all these perioperative problems. You've given us a lot of things to think about. And I know you've been associated with CSAP for a long time, and obviously things are changing in the world of continuing medical education, but I'd offer you the last word about anything you want to add about the CSAP 17 or CSAP 17 audio companion that you think our audience might find useful.
Well, there's been a lot of talk about with the changes in maintenance of certification as to where the value of CSAP is to surgeons in the future. And I think that CSAP remains a tremendous reference source, especially in areas where we might not deal with that particular problem a lot. There are sections of CSAP like the perioperative section that really span the gamut of what surgeons need to know in terms just managing people day to day, and it's a good reference and keeps a mechanism for something other than beyond going to say up to date, certainly well beyond WebMD. Not to denigrate that, but I think it offers some real insights from people who have thought about a particular problem and gone to the literature and tried to provide evidence as to what makes sense. So I think CSAP will have an ongoing major potential contribution to how surgeons continue to keep their practice fresh and how they maintain both the commitment to safety and quality care that we all really strive for.
Great comments. And again, I thank you for your contributions to CSAP and CSAP Audio Companion. And I really did appreciate speaking with you this morning. And I hope you have the rest of the day is good for you.
Same to you.
That's it for this category of the CSAP 17 Audio Companion.